Good afternoon, everyone. My name is Bronwyn Starr. I'm a senior program officer with the New York State Health Foundation. Before we begin, a few housekeeping items. This webinar is being recorded and a recap will be available in the coming days. For anyone in need of live stream captioning, you can click on the closed caption icon at the bottom of the Zoom screen and select show subtitles or full transcript options. And finally, during the Q&A portion of the discussion later on, I'm going to invite you to type any questions you have into the chat box. So thank you for joining us today to talk about public health funding, or should I say lack of public health funding. The pandemic has exacerbated cracks in our public health infrastructure in New York State and really all across the country. Funding for local health departments has been slowly chipped away here in our state over the past decade, despite research showing that higher public health spending is tied to better health outcomes. I know that one of the challenges is that public health is not sexy, it's not highly visible to the population it serves. Most of the public doesn't always understand that there are entire departments dedicated to keeping their drinking water clean or led out of their homes. Dr. Dave Choksi, New York City's former, as of yesterday, health commissioner, just gave testimony to our city council yesterday and paraphrased someone I don't know, but said, you know, public health saved your life today, you just didn't know it. And real and sustained public health investment is needed. It's needed to retain staff. It's needed to plan and implement basic programs, plan for emergencies, and to save our lives, even if we don't know it. So today we're going to hear from three very dedicated public health practitioners. Sarah Ravenhall, the executive director of the New York State Association of County Health Officials, will give an overview of the issue as it pertains to New York State. Dr. Kevin Watkins, the director of the Cattaraugus County Health Department, and Dr. Michael Mendoza, the health commissioner for Monroe County, will talk about some of their experiences as practitioners and trying to lead public health departments in the face of annual budget cuts and how this has affected their communities. Each speaker will talk for about 10 minutes and then we'll have Q&A from the audience. So with that, Sarah, I will turn it over to you.
Thank you, Bronwyn. I'm going to share my slides. Okay, can you see my slides? Okay, thank you. Thank you to the New York State Health Foundation and all of the participants who've joined us today to think strategically about the importance of funding our public health system. There are several important individuals I want to start off and recognize and thank as they were instrumental in compiling information to support this presentation. Thank you to Sylvia Pirani, a longstanding local health department partner and former State Department of Health leader, Christina Dyer-Drobnak, Molly Fleming, and Emily D'Angelo, who I've had the pleasure of working with in my office, and to all of the fabulous local health department staff and leadership for sharing their stories, which enriches my ability to build the case for public health. So to best make the case for reinvesting funds into the state's public health infrastructure, we must first think about what local health departments do to protect their communities. Public health experts diagnose the health of each community by listening to people who live there, and then use data, evidence, and research to offer solutions. They collaborate. To improve the health of the community, different organizations have to work together. Public health brings together community partners to make decisions and take action. They prevent injury and illness. So we typically end up in the doctor's office after we are sick or injured. Public health experts investigate everything that affects our health, food, water, air, and more, to prevent health problems before they start. They also do this by promoting healthy environments and behaviors. These departments also make sure there's culturally competent, accessible services available to everyone. Health equity is considered when implementing public health interventions. As I just mentioned, local health departments focus on prevention and the factors that really influence the health of a community. So I'm referring to the determinants of health. As defined by Robert Wood Johnson's County Health Rankings Project, these factors include social and economic status, health behaviors, and the physical environment, including quality of air, water, and the communities in which people live. These factors combined constitute 80% toward the health status of individuals, while clinical care contributes only 20% of the individual's health status or the population health status. Nationally, the US spends an overwhelming amount of resources on health care. Thinking about this, only 2.5 cents on every healthcare dollar goes toward public health, 2.5 cents. There's a huge discrepancy between the factors that influence our health versus how we allocate funding to support the health of a community. In New York State, spending on healthcare or clinical care versus spending on public health very much follows the national trend. The majority of all funding in New York State is directed toward the state's Medicaid program. New York's non-Medicaid health budget is only 3% of the total healthcare spending. This infographic represents the $193 per person New York spends on public health and prevention in comparison to the $3,869 we spend per person on Medicaid or clinical care services. Further, several studies show that investing more money in public health factors upstream will result in a cost savings downstream in healthcare services. New York has an opportunity now to change the narrative around funding public health interventions. And we're here today to talk about making a reinvestment in local public health. So New York is served by 58 local health departments, one in every county outside of New York City, and the New York City Department of Health and Mental Hygiene that serves the 5 boroughs of New York City. In New York State, local health departments are locally managed by their county government, though they're required to carry out state and local health statutes. We're joined today by 2 county health officials, Dr. Kevin Watkins from Cattaraugus County and Dr. Michael Mendoza from Monroe County. While I'm able to give a statewide view as the executive director of the association that represents local health departments, our other panelists will be able to share their county level examples of challenges that they're experiencing due to emergency-based cyclic funding streams and budget cuts that local health departments have seen over time. So core public health services are provided by people, the nurses, epidemiologists, sanitarians, community health workers, educators, health services, administrative staff, and others. And in New York State, these workers deliver one or more of 6 core public health services. Our public health workforce is seeing a looming retirement crisis, staff burnout, and severe recruitment and retention abilities. These conditions are critical to pay attention to as we recover from the pandemic and prepare to tackle new and emerging public health crises. Despite the important work that New York's local health departments do, they have experienced what we would characterize as a decade plus of disinvestment. There's simply been an ongoing erosion of state funding, along with increasing numbers of public health threats and new legally required responsibilities. Combined with the local pressures of the property tax cap, local health departments have been stretched thin, and these examples that you see here on the slide really fall prior to the start of the pandemic. So this is why we're supporting the PREPARE Act. We're 2 years into the pandemic. For most people in New York, the start of the pandemic was March 2020, but really it was mid-January that local health departments started to receive information from the federal and state levels regarding the novel coronavirus. Entering into the pandemic, local health departments were at a tipping point. They were already there after more than a decade of this disinvestment occurring at the state level and federal level. That really impacted the local public health infrastructure. So statewide, the number of full-time employees providing core public health services declined by 7% between 2015 and 18. And at the management level, 10 of the 58 local health officials in New York have retired since the start of the pandemic, with an additional 5 leaving for other or unidentified reasons. Which, with each loss of a county health official, we see decades of institutional knowledge and public health expertise walking out of the door. And the numbers I'm giving you are just at the management level, the director commissioner level. We're only skimming the surface. I haven't given you numbers on, nursing staff or epidemiologists and beyond. So in 2021, the Public Health Center for Innovations and the de Beaumont Foundation released a report on staffing at local health departments nationwide. This report indicates nationally 54,000 additional staff are needed to provide what is a minimum package of foundational public health services. And I would encourage everyone to take a look at that report. It's fascinating. When applying this methodology to New York State, regardless of whether they lost or gained staff over the past decade, currently about 90% of New York's local health departments do not have the minimum number of staff needed to provide these core public health services in their community. Statewide, including New York City, an additional 1,000 full-time staff are needed to achieve a minimum level of staffing and capability to provide a basic set of core public health services. So what's included in the PREPARE Act and why are we supporting it? The components of the PREPARE Act include 6 budget asks of the state. The first 3 relate to the foundational state funding for local health departments. And this foundation is established in Article 6 of the Public Health Law. It's typically referred to as Article 6 funding. It includes a base grant to each county and then reimbursement of 36% of eligible expenditures over that base grant amount. So another piece of the PREPARE Act is that we're requesting restoration of funding for New York City, whose reimbursement beyond that base amount was cut in 2019 from 36% to 20%. And then the final Article 6 ask, and a key aspect of assuring that the funding achieves its goal of strengthening the infrastructure, is making sure that fringe expenses, so benefits associated with hiring, are eligible for reimbursement under this Article 6 mechanism. Right now, fringe expenses are 100% a local government expense. And in a property tax cap world, that's a significant barrier to hiring staff locally. Fortunately, the executive and legislature recognize that there is a need for spending related to public health this year, and we're seeing that reflected in the proposed executive budget. You'll see in red on the slide where items are included in the state budget draft. Of course, the budget is not finalized, but still in comparison to healthcare spending, the public health proposal and what's in the budget at this point is really a drop in the bucket of that, $10 billion that's being spent on healthcare services. So the 5th provision included in the PREPARE Act asks for $30.3 million to prevent exposure of lead in children. These services provided by local health departments include care coordination or nursing and environmental management. So this component requests that the state fully fund the 2019 change to what is considered an actionable blood lead level, which brought about the public health benefit of identifying more children exposed to lead hazards, but did not provide the resources needed to then conduct the public health interventions to address the significant increase in workload. The long-term health effects of exposure to lead in children includes damage to the brain, nervous system, slow development, hearing and speech delays, which can cause lower IQ, decreased ability to pay attention in school. There's no safe level of lead exposure in children, and therefore local health departments must be funded appropriately to address the health source of lead and the health factors for children at risk. This is a missing budget piece that can't go unanswered this year. There's too much at risk here. Finally, the PREPARE Act includes a 50-50 split of costs for local governments and New York State for pathology and toxicology services provided by county medical examiners and coroners. Prior to 2010, these services were permissible for reimbursement by the state, but since that time became a county-only expense. Given the state's reliance on data provided by medical examiners in addressing issues such as the opioid epidemic, suicide rates, and COVID-19, we believe this must be a shared expense. As we work to reframe the importance of public health, we remind the public, our partners, and lawmakers that the healthcare system is not the public health system, nor vice versa. In order to reduce costs, eliminate health disparities, and reduce negative health outcomes, the public health system is what needs to be funded appropriately. We must act now to address the disparity that exists between the factors that make communities healthy and where we as a nation and a state spend our money on health. The past 2 years has brought immense pressure, challenge, strain to our state's public health system. Local health departments have worked with vigor to protect their communities during the pandemic. And in closing, I ask you, if not now, then when do we start funding our public health system? Thank you so much. And at this time, I'm going to stop sharing and I will turn it over to Dr. Watkins, Director of Public Health in Cattaraugus County.
Thanks, Sarah. Great job, Sarah. I'm sorry I was muted here. I'm just going to reiterate what Sarah has said as it relates to Cattaraugus County. Cattaraugus County is located in Western New York, and we are one of the 58 county local health departments. And we are considered a very medium-sized local health department with 110 employees. About 10 years ago, local health departments were asked to move away from the medical model to a preventive health model for service delivery. Eventually, grant funding for various programs were eliminated. So we were, so were certain state reimbursement for certain local health department programs, as Sarah has indicated. This led to job losses in the local health departments and an overall depletion of the health department's infrastructure. Statutorily, local health departments are required to provide a variety of public health services under 6 core categories in order to be reimbursed the state aid. Those 6 core categories include family health, communicable disease control, chronic disease prevention, community health assessment, emergency preparedness, and of course, environmental health. Programs that were once part of the state aid reimbursement and the local health departments were allowed to continue, but 100% of the expenses, Sarah indicated, had to be picked up by local health departments. And as you would expect, county government required local health departments to eliminate these programs that were causing increased county expenses. Some of these programs that were no longer state aid reimbursable include for instance, our certified home health agency. Cattaraugus County is one of 10 local health departments that still have a certified home health agency. But state aid reimbursement was eliminated, and these programs were, in most local health departments, they were either sold or they were folded. And the nursing staff, who had the largest number of staff within these programs, were no longer part of the local health departments. Clinics like primary care clinics and dental clinics, state aid reimbursements were eliminated. So these programs were either cut or they were contracted out to the private sector. And again, nursing staff, who had the largest number of staff within these programs, were no longer part of the local health departments. Laboratories. Cattaraugus County is one of very few local health departments that still have a clinical laboratory. But state aid reimbursement were eliminated in these programs, along with the staff. They were also eliminated, and therefore staff like laboratory technicians were no longer part of local health departments. Health educators. These are individuals who put on programs within the community, but these programs were no longer supported by grant funding, and most of these positions were eliminated through attrition. And then preventive health. Screenings for hypertension, diabetes, cholesterol, bone density. Well, state aid reimbursement were eliminated, and these programs, along with the staff, mostly nursing staff, were eliminated as well. Cattaraugus County Health Department did not experience a large loss of staff before or during the pandemic, but we did face attrition in several position categories. The largest decrease in Cattaraugus County was our financial operations staff. We had a decrease of about 55% of that staffing. Currently, there are about 6 vacancies within our department. We have 2 public health nurses, community health workers, and we have 1 health educator and a public health physician. These are vacancies that need to be filled within our department. As public health has evolved over the years to take on new health initiatives like cooling tower investigations for Legionella, lead monitoring in schools, writing of an annual Zika action plan for community-wide Zika virus. As these new initiatives are instituted by New York State, new staffing is never part of those plans. And over the past 2 years, New Yorkers have had the opportunity to see their local health departments in action as they rose to the challenge of the COVID-19 pandemic. COVID-19 really unmasked the weakened infrastructure of our local health departments. During the peak of the pandemic, additional staff had to be recruited from other county departments here in Cattaraugus County in order to assist us in carrying out our workload associated with this pandemic, because our health department were depleted of our staff. And now that the pandemic has started to retract, that workforce that was brought into the local health department here has now been extracted from the health department, and we're still left with a weakened infrastructure. The toll that COVID-19 response took on local health departments have been unmeasurable, as local health departments are still trying to assess the impact that the response has had on our departments. As Sarah indicated, we've had loss of personnel like commissioners, health directors, nurses, and a host of others. And we're still feeling the impact in local health departments throughout New York State. Now, while we appreciate the federal funding to control COVID, it has been challenging to keep up with the increasing demand on the fiscal and the operational staff that come along with accepting new grant funding. The increase in funding to local health departments when there is a new public health emergency, it creates challenges in staffing. It is already hard to recruit and retain staff, but nothing have really been dependable as far as funding that you can count on that makes it less desirable to fill vacancy within our departments. Within the ability to hire due to state's property tax commitments, ineligibility of fringe costs, or lack of increase or sustainable funding, it challenges our public health response capabilities. While public health has faced many challenges during COVID-19, including outdated infrastructure, a beleaguered workforce, and inequities in access and outcomes, the lasting lesson for policymakers must be recognition that these structural shortcomings were not caused by the pandemic, but rather already endemic after decades of chronic neglect and underinvestment in public health. To conclude, investment in public health workforce is critical in order to recruit and retain a responsive and skilled public health workforce that can provide the communities they serve with a base level of protection and take prompt action in public health emergency. Thank you. And I'm going to turn this over to Dr. Mendoza.
Thank you, Dr. Watkins, and thank you all to everybody who's had the opportunity today to join us for this important conversation. As you heard, I'm Michael Mendoza. I'm the Commissioner of Public Health for Monroe County. I'm also a family physician by training, and I joined the health department in Monroe County about 6 years ago because I noticed that we were not doing well enough in our county, tending to the healthcare needs of our population. We have one of the most efficient healthcare systems in the nation. We have probably one of the best medical centers in our region. And nonetheless, not only do we have depressed health outcomes, we also have a very unfortunate amount of disparities in those health outcomes when you look between those who have and have not, particularly around the areas of poverty and access to healthcare services in general. I had also joined the health department those 6 years ago because a lot had been spoken about it at the time around population health. And at the time, population health was very much focused on bundled payments, Medicaid reforms, healthcare practice transformation, and other interventions which would improve my life as a primary care physician. But with all of those conversations, the only way we were thinking about our population was about who their healthcare coverage was being provided by. Were they Medicaid, Medicaid managed care, Medicare, private pay, and so forth? And I had a fundamental problem with that, because when I think about the public, I think about everybody. I think about everybody who lives in our county, who lives in my neighborhood, who lives in the zip codes that my practice serves. And it became very clear to me that we would not be able to address population health solely through the provision of healthcare services. Furthermore, I believe that we will not do well as a state or as a nation if all we do is support primary care medicine. And believe me, I think we need to support primary care medicine to the fullest extent. But when you think about investments in primary care medicine, again, it's investments in healthcare services. And as you heard, only about 2.5% of our healthcare spend in New York State goes to public health and prevention. I think we can all agree that it is much preferable to prevent cancer than to treat it. And when we think about the work of public health departments, about public health professionals, our focus is to stay in the background, to do the work of prevention, to try to keep people healthy and to try to keep people from needing to access treatment and diagnostic services from healthcare. But unfortunately, we have the most expensive healthcare system on the planet. When you look at percent of GDP, when you look at per capita spend, the United States has the most expensive healthcare system on the planet by a long shot. And so to think that we're going to heal this nation's healthcare and health by simply spending more is only going to make the most expensive healthcare system on the planet all the more expensive. So we need to think more wisely about how we spend our healthcare dollars. I'm not advocating for cuts in spending to healthcare, but I am advocating for a relook at how we distribute the dollars that we spend between healthcare and public health. There is more than adequate resources being devoted to healthcare services. And as you heard earlier, an inadequate amount being devoted to primary care and public health services. When you look at the most important expenditure in healthcare or in public health or in local health departments, by far it's the people. And this became very evident through the last 2 years in the COVID pandemic, when workforce shortages were experienced throughout all sectors, whether it's healthcare, public health, or in business and the economy in general. We realized very, very acutely that we would not be able to move forward unless we had that workforce available. The workforce to take care of our loved ones in the hospital when family was not able to visit. The workforce able to care for our patients when they were discharged from the hospital in the nursing homes. And we also saw the sensitivity of our brittle healthcare and public health workforce in the face of the COVID pandemic. When we saw the earliest cases of COVID were among the most least paid, lowest paid employees in nursing homes. The reason we had early surges of COVID in nursing homes was because we did not adequately fund public health and the staff that we had working in our nursing homes. We didn't have the ability to share data between healthcare and public health so that we can serve the needs of our nursing homes. And so this is yet another example of how the COVID pandemic has shined a light on disparities that we have had for a long time. So we not only need to spend more money on public health, but we need to think more about the workforce. And speaking as a physician, I don't actually think we need more physicians in public health, because physicians tend to be highly compensated. And the reality is we need more specialists in all the other areas of public health that you heard about today. When I think about my public health department, we have about 255 staff. Our budget is about 65 million when you include environmental health. And the smallest proportion of my staff is devoted to chronic disease prevention and management, which since the year 2000 has been shown to be the largest contributor to death and premature death in the United States. By the same token, we have a fair amount of spending in environmental health, but unfortunately, we're not spending those dollars very wisely. We're not adequately funding lead prevention. For example, as you heard, again, it's much easier to take care of lead prevention by preventing lead poisoning. But unfortunately, our current system waits for children to have an elevated lead level before we act on trying to prevent lead poisoning. So we need to think more broadly about the public health workforce, and the way we do that in health departments is through stable funding. My department, unfortunately, has struggled in the last 2 years, as all health departments have, trying to meet the needs of this pandemic. And you might say to yourself, well, pandemics only happen once every 100 years. But the reality is we've had many pandemics and epidemics in my health department and in my county, at least every year since I've been here. So these threats are not going to go away. And if we don't adequately fund the people, the workforce in our health departments, unfortunately, the expenditures going ahead will only get worse. And as we think about the wake of COVID, I think it's too early to say what the full impact of this pandemic will have on public health, on healthcare, on health outcomes, on society. But it's very clear that we saw huge disparities in outcomes, in vaccination rates, in hospitalization rates, in mortality, particularly among traditionally medically and public health underserved communities. The poor, the rural poor, the urban poor, those without adequate access to healthcare, those without adequate access to clean water, to food, healthy food, transportation. All of these ills will not be served simply by funding healthcare. We have to think about how we can fund both health departments and the workforce in our health departments in order to address these disparities. So with that, I'm going to pause and send it back over to Bronwyn, and be happy to take your questions.
Okay, thank you, Dr. Mendoza. Thank you, everybody. Yes, please, there's a lot of comments in the chat box, but please feel free to start populating the chat box with your questions. There is one that I wanted to kick off with. I think it's directed more towards Sarah, but I think the question is, what are the gaps in the spending or allocation between the Prepare Act and the executive budget? And then so that's the question from the audience. I wanted to tack on my own question about that. You mentioned this is, all of this is still a drop in the bucket. And I want to be careful about going down the district Medicaid waiver rabbit hole. But if we were to see a 2.0 here in New York State, is there any proposed funding support for local health departments within that?
Absolutely. Thank you, Bronwyn. That's a great question. And thank you to, I think it was Ellen that put that in the chat. So I'm going to put a link to the Prepare Act website on NYSHealth's webpage in the chat box, but I'm going to answer your question about what is in the executive proposed versus our Prepare Ask. So we're having a somewhat of a good year. We're seeing some interest and recognition that funding is needed. 3 out of our 6 proposals were in the executive's budget. The governor has been very supportive of the work of local government and very responsive to the fact that there is a need within local health departments for funding. And how I know this is that we've had conversations, but we're seeing 3 out of those 6 asks in the budget. So what we're seeing in the executives proposed is an increase for the base grant funding for full service and partial service local health departments. That's about 15.2 million. And then we're also seeing, that is 15, about 17 million. We're also seeing fringe being proposed as being eligible under Article 6 reimbursement. And so how that's being proposed is that if a county local health department has a fringe rate for employees that goes over 50%, then anything beyond that 50% is not going to be eligible. So it's fringe eligibility up to 50%. And one of the things we'd like to see is for that fringe cap of 50% to be completely removed. I don't think that the fringe rates are something that the counties or local health departments necessarily have control over. So we feel it's really important that the state recognize that. And one of the interesting pieces I'll mention is local health departments seem to be one of the few local agencies where fringe is not and has not been an allowable expenditure. So you're looking at your mental health counterparts, social service, they have some sort of fringe rate that is allowable to be reimbursed by the state. We also, regarding the lead prevention ask, which is $30.3 million, that is not yet in the budget. However, we are expecting to see Assembly and Senate One House bills either today, tomorrow, Saturday. So we're hoping that we have been vocal enough about that. Really, that's not something we can skimp on. And we're not asking for more money. We're asking for the money that's needed to locally implement the 2019 lowering of the elevated blood lead level. This is something that our communities deserve, and children who are exposed to lead absolutely deserve. So that's very important. Also not in the proposed executive is the 50-50 pathology toxicology ask. So, hopefully we can make headway on that as well. But I hope that answers your question in terms of what is in the budget, the proposed versus what our asks are. The other piece on the Medicaid waiver, without going into a rabbit hole, is yes, the state is looking at submitting the next iteration of the Medicaid 1115 waiver application. And two of their primary focus areas are health equity and emergency preparedness. Now, these are bread and butter, fundamental local health department responsibilities. So it seems as though there's an obvious role for local health departments, but as far as I've seen, there's no completely defined role for local health departments within that proposal. And we've had conversations with the State Department of Health and Medicaid director on this. One of the things they have outlined in this proposal is the HERO model. So Health Equity Regional Organization model. And the main primary function of these heroes is consensus building, serving as a central hub to address health equity and bring different partners together to improve health outcomes. Local health departments are eligible to apply for that hero role. But beyond that, we don't have any other defined role, and we want to be very careful. And I think the state seems to recognize we don't want to duplicate efforts or step into responsibilities that local health departments have statutorily when we apply for this next iteration. But that could be money that certainly supports and helps fills the cracks within these workforce shortage gaps.
Thank you. Okay, so I have a question for Dr. Watkins, Dr. Mendoza. Can you speak to the role of public health nurses in your counties and the maternal child health programs? Are those still the funding for that? Like, where are the gaps in that? How robust are those?
So go ahead, Kevin.
Go ahead, Mike. Okay, well, for Cattaraugus County, we still have a number of public health nurses. As I said earlier in my presentation, we're one of the few local health departments that still have a community, a certified home health agency. And so I have at least 20 to 25 nurses just in that particular program itself. Our maternal child health program still has 2 nurses in that program, but as far as the funding is regarding those programs of public health nurses, the Certified Home Health Agency, they are a revenue generating agency that is able to support itself. And so that's one of the reasons why the county legislators have decided to keep that program on board. And as far as our maternal child health, although that program oftentimes have to be supported by county tax dollars, the importance of that program has signified the need to continue that program within the department. And so our county legislators have maintained that program as well.
So with regard to nursing, one of the challenges that we're experiencing in nursing is not so much a shortage of nurses in general, although there is a shortage of nurses in general, but it's a very drastic shortage of nurses who go into public health. Nurses are by every measure a critical workforce in all of healthcare and all of public health. But hospitals and healthcare systems are in a position to compensate them much more competitively than public health and health departments or public health programs in general, whether they're in a health department or not. Add to that the fact that we are not recruiting a diverse enough workforce into the nursing field. When we look at the nursing workforce that's necessary to attend to public health, we are not doing well enough recruiting from traditionally underrepresented minorities in healthcare, whether African-American, people of color in general, people from backgrounds of poverty. Those individuals are not traditionally represented in the workforce. The way we address that shortage is by recruiting a more diverse workforce. And in many cases, the entry-level types of jobs like nursing assistants, public health nurses, LPNs, many of them can find a home in health departments. And so we have tried to recruit more people of color into these roles, supporting the few nurses that we do have in our health department as a way of trying to diversify the pipeline of people going into nursing, whether they end up going to healthcare nursing or public health nursing. But the reality is we need to use our nurses more effectively in public health in general. We don't have enough nurses. And so that's why we need to support the programs that then allow us to compensate other individuals who may be considering a career in nursing down the road. But I think that begins by funding people in public health who are interested in trying to prevent illness, and particularly in the backgrounds that they often represent that have been traditionally underrepresented in public health and health in general.
Thanks, Dr. Mendoza. So this is a question, I think, again, for the doctors. I'm going to combine a couple of questions here. And Dr. Mendoza, you touched on this, that there's a lack of diversity, racial diversity, economic diversity in the healthcare system as it pertains to clinicians. So is there can you guys comment on sort of discussion or consideration around community health workers, local community organizations, faith-based organizations? How can they be helpful in sort of, addressing the gaps in the workforce? Yeah, I'll leave it at that. Oh, you're muted, Ian, you're muted. So unmute yourself, please.
Thank you. Sorry. In my career prior to entering the health department, I spent most of my career looking at primary care workforce teams with an eye toward diversity, because unfortunately, many of our patients who have suffered from decades of poor access to healthcare are from many of these traditionally underrepresented backgrounds. So it stands to reason that if we can recruit people from these communities who can serve their neighbors, their co-parishioners, their relatives in some fashion, it shouldn't be a surprise that we can one day rectify the decades-long disparities that we've been seeing in health. Unfortunately, one of the challenges in medicine is that you need a credential, you need a professional certification, often you need a degree to function in these roles. In primary care medicine, and I had clinic this morning, we don't have anybody of the title that you've mentioned: community health worker, lay health educator, peer support worker, patient navigator. All of these titles would be very, very effective in primary care, but unfortunately they don't have the credentials necessary. And so from the overhead standpoint that you have to think about from a primary care practice perspective, there's no way to reimburse, there's no way to compensate these people. So unfortunately, we can't find a way to afford them. The same is not true in health departments. It's much easier for me to find a way to employ these individuals who may have aspirations to go back into healthcare someday, but just don't have that first step. It's much easier for me to recruit them into the health department, get their feet wet, build that passion for serving the public, for serving community health, for trying to advocate for prevention. It's much easier to do that from a compensation standpoint, but unfortunately, we don't have the funding to pay for those people. We have the programs, we don't have the restrictions that insurance companies might impose, and so it's much more accessible for me to hire these individuals, but unfortunately, we don't have the means to do so. So, I believe that if we do not diversify our public health and healthcare workforce, we're going to be in a world of hurt very soon. And so we need to start now. And I think the way we do that is by opening doors for positions that are more accessible to people who have been traditionally left out of health and healthcare.
Thank you.
I agree with my colleague 100%, and I guess I would just ditto those comments as well. Community health workers are an important asset to the public health workforce, and without them, it oftentimes you need someone who can relate to the public. And oftentimes, when they see public health officials coming in to talk to them about various things that deals with public health, we are at a different level, and oftentimes these community health workers can actually talk on the level that will produce positive behaviors in a number of our residents. With that being said, we have to start in the high schools, we have to start that recruitment in the high schools. And then when there are opportunities in local health departments, we need to offer those opportunities to those individuals who are less likely to be offered those positions. Here and recently, we've had the opportunity to hire these public health fellows. This would have been an ideal time to introduce public health to those who are not normally in public health. The diverse background of individuals that we have within our community can apply to these public health fellows programs. It gives them an idea of what public health is all about. And I think more programs like that initiated by New York State could potentially really increase the workforce for public health.
Thank you. Another question, I'm going to read this because I'm not sure I completely understood. I'll try not to translate it too much. I'm just going to read it. So do you see a shift towards a less reactive, obviously the past 2+ years have been very reactionary, but a less reactive and more strategic solution to issues around these challenges? So like COVID, but also the past decade of the disinvestment. How can we be more strategic around some of the challenges?
Well, I would say that the work of local health departments is very evidence-based and strategic. Sometimes local health departments are like very silent prevention warriors behind the scenes. But they're always there using data to develop interventions to help improve health outcomes in communities. So maybe that strategy isn't always seen, but it's certainly there. And I'm not sure if that answers the question.
Maybe I'll add that I worry that we're not on a strategic path. I think there's great evidence of strategy being utilized to guide the way we think about funding opportunities. But I also worry that, even in the prior administration, as well as in this one, that expectations were being placed on health departments that suggested that there wasn't a recognition of what the local health departments were being tasked with. So an example of that is in our schools. I have worked very closely with the schools for the last 2 years to institute the various mitigation strategies to prevent the spread of COVID. And we were put in a position to enforce in many cases, whether it's in the schools or in the community. But local health departments don't have a mechanism to enforce mask wearing, for example. And that made me wonder whether there was truly a recognition of what local health departments can and cannot do. I don't believe that local health departments are fully equipped or even legally permitted to enforce these state laws, these state statutes, these state mandates. But when we saw these expectations being levied on the local health departments, honestly, it made me worry. I think we need to begin with a greater appreciation for what local health departments do, for what they do not do, for what they can do, and for the areas where they really can't do very much. I think once we have that in place, I think we can then begin to be more strategic about how we fund local health departments. But until there's that recognition, I do worry that local health departments will be asked to do more and more with less and less.
Right. Okay, there are a couple of questions. I'll summarize them around data. And I think Sarah talked about there's data to support a lot of these programs and initiatives and the return on investment for supporting public health infrastructure. So, but in terms of, I think the question is more, one, accuracy of the data that you have. And I think, again, this goes to a comment Michael made at the beginning of the conversation about sharing data between healthcare systems and public health. And then also data related to specific areas of concern, like lead, for example, or in other environmental risks, and the disease mapping that goes on?
Yeah, I would say in New York, there is a need for a really updated, integrated data system to increase transparency for public awareness around public health issues. It's something that NYSHealth is certainly always talking about and advocating for. I know that our members locally do collect data that's specific to their community, but we need it to be able to be funneled up and transparent to communities, because really, you know, when we're talking about public health funding, we want to use the public as our proxy. And we need the public support and going to lawmakers and raising awareness for the importance of public health.
That's it. So there's another question I wanted to have saved for one of the last questions, but someone was asking, how can New Yorkers talk to our legislators and executives about public health funding and lack of public health funding and where it should be coming from?
How operationally, you can go on the New York State Assembly website or the New York State Senate website and put in your address. They will tell you who your elected officials are, and you can reach out to them. You're a constituent. They want to hear from you. I guarantee you that. If you're talking about what issues to address, you can always, you know, what's impacting your community. You know best, right? But you know, from a statewide perspective, you can always look up. There are statewide associations. The Health Foundation has information on their website. NYSHealth has more advocacy information on their website, nysho.org. There's also a New York State Public Health Association. You know, educate yourself and definitely reach out to your lawmakers.
Thank you. Someone pointed out, there are advocacy days, coalitions that, you know, the more the merrier, I think in this case. I think that we'll begin to wrap up, but someone made the comment to one of our earlier comments about Minnesota, the state of Minnesota mandating that health plans work in tandem with public health, to have, I think to your point, Sarah, to develop more common languages, common strategies to improve, you know, not just help the people who are sick, but to prevent the disease, the progression of disease. So I don't know if there's any, you know, how you guys work in tandem with your local healthcare systems. I know it's different for every county, every region of New York. So this might be kind of a big question to talk about, but maybe specifically to Monroe County.
Well, so in Monroe County, we have a community health improvement work group, and that's a collaboration between the healthcare systems and the health department. And that's a requirement for tax purposes under the Affordable Care Act for hospitals to retain their nonprofit status. So rather than each hospital submitting their community health improvement plan, we in Monroe County developed a work group that was a collaboration of both healthcare systems and the health department, so that we could arrive at what we thought would be more representative, more shared goals for health improvement. That's just one example. I believe that this model exists in other regions, but it's only the tipping point. It's only the start. We need more than that. We need collaboration with nonprofits. We need collaborations with schools, churches, pharmacies, libraries. And there really is no formula for how to do that, but there's certainly a need, and the last 2 years of a COVID pandemic certainly proved that for us.
Okay.
And for me, living in a rural community, we have one hospital, and so it's very easy for me to have that collaboration. So there is an open collaboration with our one hospital. During COVID, for instance, I held my daily meetings with the hospital in addition to our federally qualified health center, and all of the medical providers would come and log in to that 15-minute meeting that I held during COVID. And currently, doing our community health assessment, we have partnered with our local hospital here to prepare a community health assessment that will encompass the segments that we cover and the hospitals that are covered by the hospital. Our hospital also is associated with a hospital in Pennsylvania as well. So we'll have Bradford Regional Medical Center in addition to Olean hospital, in addition to the local health department, in a document that will encompass the needs of all of our communities here. So I think it can be done. It's just a matter of just having that type of relationship with your medical providers within your community. And I think that once that has been established, then we could really strengthen the health outcomes of these various communities.
Thank you. I think this will be the last question. Is there anywhere we can go, any one single source to see how health-related funding flows in each area? So I think the idea is that how would that could help us answer the need for discretionary funding, gaps in funding, subcontractors for things. And again, I think this might be a county by county or regional issue, but maybe Sarah.
Yeah, I think state allocated funding, you can get a state sense from the state budget, but that doesn't answer the question about the cyclical federal funding that comes through. And just a note on that, while we appreciate federal funding coming through, it's not disease agnostic. So it has to be used in a very specific way to address a certain issue, which does not give us a lot of flexibility. And then, it may be a 5-year funding cycle or a 1-year funding cycle. So that makes it very challenging to plan ahead and hire, because once that funding ends, where's your money to support that individual, that staff person coming from in the future? But I like that idea. I would ask Michael, Dr. Watkins, and Dr. Mendoza if they have suggestions on the subcontractor piece of that question. But there's no one centralized place that I'm aware of where you can see all the funding going to one local health department.
Right. I think digging into the actual budget at your county or municipal level will give you a sense of that. The year over year won't necessarily tell you the entire picture. Certainly if it's going down, that's very concerning. But even though my budget has expanded over the last 6 years, it has not kept up with the rate of inflation. And it hasn't even kept up with the rate of hiring that I've needed to undertake in order to take on these additional grant deliverables and mandates. So the number alone doesn't tell you the whole story. So I agree with the comment here on Trust for America's Health that has some great information, but I do think you need to dig a little deeper because the total number only tells part of the story.
Okay. So we are at time. I want to just thank everyone, all our panelists, for being with us today, for everyone participating. We had a very large audience today, so I think that just reflects the timeliness and urgency of this issue. So please, I hope you enjoy the rest of your day. Finally, please check out our website, NYSHealth. We're going to post a recap of this event and the slides in the coming days. And we also have resources on our website around some of these issues. And we have other timely events coming up. So thank you, everyone. Enjoy the rest of your day.
Thank you all.
Thank you.
Thank you.